My name is Hani Sabbour. It's a pleasure to present to you year in review, a focus on cardiac electrophysiology. So the last year has been quite exciting in electrophysiology. There's been a lot of advances in the arrhythmia mechanisms, diagnosis, and new therapies. For those of you who like basic electrophysiology and molecular biology, we found that secretioneurin is actually a biomarker for the risk of ventricular arrhythmia. And natriuretic peptide receptor C in atrial fibrosis has been implicated in atrial fibrillation, and specifically a channel called TASC1 as a therapeutic target as an antiarrhythmic. We've seen studies showing the role of sensory neurons in sleep apnea-related AFib and the association between bariatric surgery and AFib ablation outcomes. Artificial intelligence is very exciting, has been actually applied to electrocardiography, actually yielding correct estimates of age, gender, and overall health, and tools for patient-centered outcome after catheter ablation. So this I found really fascinating. So this is a very large, what they call neural network analysis, which the ECG actually was able to predict the age in blue versus the true chronological age in red. So it's a direct linear correlation. It's a perfect correlation. And in fact, it was able to classify groups into patients into groups of age, 18 to 25, 25 to 50, and 75. And it corresponded very nicely to the actual age of the patient. In addition, it's also able to predict sex also from the ECG. So more is coming. If it's able to do basic epidemiology, then I'm sure it can do more. And this is from just automated ECGs with artificial intelligence. Another important finding that we saw was this very large paper that looked at the association of RV dysfunction and sudden death. All of us are familiar with the cutoff points for left ventricular ejection fraction, 35% for ischemic and 30% for non-ischemic, with risk of sudden death. But you see these patients with right ventricular ejection fraction less than or equal to 45% at a significantly greater risk of sudden death. So another marker of sudden death as well, and possible indication, although in the future, for ICD. In addition, through high-density mapping, we are now able to see ventricular tachycardia termination sites during ablation. As I mentioned before, right ventricular dysfunction is a predictor of survival after ICD implantation in non-ischemic cardiomyopathy patients. We've also looked at and adopted actually a lot of the His bundle pacing and what we know as left bundle branch area pacing. Some more advances in what are called cardiac laminopathies and new tools to predict arrhythmic events in patients with genetic cardiac disorders. So here's another very important paper that actually looked at the likelihood of having atrial fibrillation lifetime in patients who had a long QT3 genotype. So this is actually fascinating because we have associated long QT3 with sudden death, but now we can see an almost fourfold probability of atrial fibrillation as well. And this is lower, in fact, in patients who are long QT1, and long QT2 appears to be protective against AFib. Another important advance was the use of the adenosine challenge test in patients with syncope and unknown origin. So starting with this algorithm is a very practical algorithm, syncope of unknown origin. So there's a normal echo, normal Holter, normal echocardiogram, but recurrence and severe presentations, so syncope with injury, without any prodrome, and particularly in women above the age of 40. So if the head-up tilt test, so a tilt table test, is negative, adenosine challenge can be done. If it's positive, it'll show you practically this. So with the adenosine challenge test, you actually see this progressive asystole lasting for more than 6 seconds. As you see in this patient, the patient actually had asystole for almost 25 seconds and high degree AV block. That is characteristic of paroxysmal AV block in these patients. And this is an unusual form of syncope that's only unmasked by this mechanism. If the adenosine challenge test is negative, a loop recorder might be recommended. Of course, if it's positive, this is a patient with paroxysmal AV block, and a pacemaker would be appropriate in this case. Now, if the tilt table test is positive and the patient has a bradycardic response, then a loop recorder would be also reasonable. If on the loop recorder you see recurrent paroxysmal AV block or asystole, then pacing would be appropriate as well. Additional insights have been published about new mechanisms of ablation. Traditionally, we use cryoablation or radiofrequency ablation. This is a new technique. It's called irreversible electroporation. And this is a remarkable pulse that is delivered through this circular catheter. And it actually lasts for about 6 milliseconds. It's extremely fast. And you basically give 2 or 2.5 pulses per pulmonary vein, and results in a fairly robust isolation, and without really having to move the catheters a lot. It's basically going through this circular catheter. It does require a little bit of a high voltage and myocardial stunning, but this is the concept that's going to make probably ablation a little bit easier. So it's non-thermal. There's acute pulmonary vein isolation. We'll have to see the long-term effect. The safety profile is comparable or better than RF, but maybe equivalent to cryo. Simple catheter design, takes a few milliseconds and doesn't require any catheter manipulation once you are in the target site. Some really important insights now about splanchnic nerve block for acute and chronic heart failure. So this is very promising. This was initially published in 2018 for patients with acute heart failure, and this is the concept that with splanchnic nerve block, there is reduced volume distribution, and there's reduced splanchnic vascular tone and increased vascular compliance. This is actually done by an interventional radiologist, injecting the splanchnic block in the paraspinal area here under fluoroscopy. Pulmonary artery catheterization was performed simultaneously in this study, and the wedge pressure drops very significantly. Systemic vascular resistance also drops significantly. So there's a marked reduction in the filling pressures and an increase in the cardiac output, and there's a significant reduction in systemic vascular resistance and arterial compliance. So this may actually be an important player in volume regulation in acute and chronic heart failure. So what's new is what was published last year and presented also. These particular patients, again, they undergo splanchnic block, and the long-term effects, these are patients with chronic heart failure, is you see a significant reduction of the right atrial pressure, the mean arterial pressure, the wedge pressure comes down very significantly, and the pulmonary artery pressure as well, and the systemic vascular resistance. So very positive in terms of patients' hemodynamics. And as monitored invasively and non-invasively, there's a significant improvement in the thoracic fluid content, and this also with and without exercise. So this seems to be a very promising early stage, short-term effect in patients with acute and chronic heart failure. So we saw improved resting and exercise-induced hemodynamics, favorable improvement, and targeting the splanchnic autonomic nervous system to treat heart failure can be a potential therapeutic target not currently used, and will need more evaluation in the future. Now, the big thing in EP right now is actually physiological pacing. So we've had many different ways to improve pacing, to improve heart function, from right ventricular pacing to CRT, His bundle pacing, what is called conduction system pacing, and the most recent one, which seems to be extremely promising, left bundle branch area pacing. So historically, pacing from the RV apex has been used to treat bradyarrhythmia. However, while it is reliable, it has been seriously challenged because long-term RV apical pacing has resulted in heart failure. So now options for what is called conduction system pacing to maintain electrical synchrony has become very important and widespread. So this is what's called left bundle block area pacing. And you can see this was a systematic study where they actually put catheter next to the His bundle, you see here in red, and next to the left bundle, which you see here in green. And they tested the differences in terms of QRS, outputs, and feasibility. Now, historically, right ventricular apical pacing is deleterious in patients with LV dysfunction because pacing the right ventricular apex causes abnormal electrical activation, right ventricle first, and causes inter and intraventricular dyssynchrony. And this will cause LV remodeling, myocardial perfusion abnormalities, and have caused worsening LV function. And this is basically mechanical dyssynchrony, which causes left atrial remodeling and can lead to AFib, and electrical dyssynchrony that makes LV function worse and increases filling pressure. So both heart failure and AFib result from RV pacing. Now, there are various tips and tricks that you can use in a conventional pacemaker to reduce ventricular pacing, that is AAI pacing, or put the VVI at 40 so the patient never paces. Or in patients with, put a very long AV delay. There are special algorithms that switch from AAI to DDD, so to avoid ventricular pacing, or dynamic AV delay that makes it longer and longer. However, none of this is perfect if the patient actually has AV block or progressive conduction system abnormality. RV pacing causes AFib and cardiomyopathy. And of course, this can manifest over many different types of ejection fraction, de novo cardiomyopathy, or pre-existing heart failure. And we can't really predict which patient gets it, but it has to be monitored carefully. So this is a very important prospective study that looked at comparing His bundle pacing versus left bundle area pacing. And essentially what you're trying to do is capture whatever is left of the conducting system. This will allow cellular conduction to occur through the rapid conduction system, the His-Purkinje system, and restarts resynchronization. Now, His bundle is a very narrow zone with a lot of fibrous tissue. It's technically challenging and electrically inert fibrous tissue, and in patients with AV block is not easy to achieve. Plus electrically high thresholds. Left bundle, of course, is a larger area. It's a more less constrained area. And in the echo, you can actually see that you actually insert the lead quite deep into the septum. And you're likely to have a wide target zone. It's a lot of muscle, so capture is more likely, and there's a high success rates in AV block. So it has a significant benefit. And one of the important review articles that was published last year from Kenny Ellenbogen's group in Virginia is looking at this as a perfect compromise, as it were. So it is a very helpful solution. It's favorable anatomically and histologically. There is dense myocardium and a large target zone because it's a thick band-like structure. You can actually pace the left bundle from the main trunk or the fascicles. It's technically easier, the shorter learning curve. And enlarged RV cavity with a thick septal fibrosis are technical hurdles, but even with that, success rates are very high. In addition, it allows stable and reliable lead parameters, so it doesn't drain the battery much. You don't need a backup RV lead, so you can simply put the left bundle branch pacing and an atrial lead and you're done. Therefore, the complication rates are lower because you have one less lead. The increased threshold and loss of battery is unusual. Septal perforation rarely occurs, but again, has to be monitored closely, and you have to use guided echo as well as fluoroscopy techniques. You can usually see this intraoperatively, and the lead can be repositioned relatively easily at the time during the procedure. We just have to look at the long-term follow-up, which will be clear later. Now, pacing from the left bundle does not result in a right bundle branch block, but in a right ventricular right bundle conduction delay with a narrow QRS. So interventricular dyssynchrony will be more limited. When RV activation delay is of clinical importance, we won't know until longer term studies are seen. And sometimes you can actually see what's called bipolar capture pacing with anodal capture of the septum. So you're actually getting two different vectors from the same lead, can actually attenuate this synchrony because you're actually pacing both sides of the septum simultaneously. And you have to program carefully to allow the AV delay to fuse as well. It preserves the LV synchrony, and in patients with heart failure and left bundle branch block, it actually improves synchrony, makes the QRS duration almost the same as CRT, and is actually very promising as a future alternative to standard BiV. And it also allows cardiac resynchronization with high rates of success, significant QRS duration reduction, improvement in ejection fraction, and clinical status improvement. I think we have to go back historically. His bundle pacing was described 20 years ago, but it's extremely challenging. And without a significant change in the technology, his bundle pacing has been really difficult for many operators. So left bundle branch area pacing is much more universal in terms of its application. There's a lot of interest in this left bundle branch area pacing. It's feasible, safe, and effective, and gives you good long-term lead parameters. And a lot of descriptive studies show advantageous outcomes as well. This is a recent study, again, that was published in the JACC EP. And you can see here, in these patients who left bundle branch block pacing was achieved, not his bundle pacing, ejection fraction improved by a factor of at least 15%, end diastolic diameter, functional class, and QRS duration were all significantly improved. And I think this really tells us that we have to learn this technique. For people who implant pacemakers, it's not particularly challenging. It's literally just a special catheter that you have to use and manipulate, and just learn to target the deep portion of the septum and use the fluoroscopic and echo landmarks. And with that, I think I'll end my sort of short tour of what's new in EP and open back to the chairpersons and go back for questions. Thank you.